Welcome to this explainer. Today, we're putting on our clinical detective hats. We're going to unpack the highly structured criteria for identifying and treating bipolar disorder. And this isn't just about recognizing a few mood swings. It's about really understanding a complex, multifaceted clinical condition that requires absolute precision to diagnose and a highly systematic approach to treat safely. The stakes here are incredibly high. A misdiagnosis that can easily lead to incorrect, potentially harmful medications that just worsen a patient's state. So get ready to take some mental notes as we break this whole thing down.
It really all boils down to this fundamental question. How do you accurately diagnose and manage bipolar disorder? In a clinical setting, you absolutely cannot rely on gut feelings. You need a rock-solid, step-by-step pathway to separate the true condition from a lineup of alternate suspects. We need to know exactly what signs to look for, what alternatives we must decisively rule out, and the precise pharmacological steps to take once we actually have our diagnosis locked in.
Okay, let's dive into this. First, classifying bipolar disorder. Second, spotting the signs. Third, diagnosing a manic episode. Fourth, ruling out alternatives. And fifth, step-by-step management.
Section 1. Classifying bipolar disorder. The very name bipolar tells us that this condition operates between two distinct poles. On one end, we have the low mood, which represents a major depressive episode. And on the completely opposite end, we have the elated mood, which manifests as either a full manic or a milder hypomanic episode.
The strict dividing line between the two main types is super fascinating, and it's where our detective work truly begins. Bipolar I hinges entirely on mania. If a patient experiences just one single manic episode, boom, they meet the criteria. That's true even if they have never actually had a depressive episode. In fact, 5 to 10% of these patients show only mania. Bipolar II, however, is a totally different presentation. It absolutely requires a combination of both a milder hypomanic episode and a full episode of major depression.
Section 2. Spotting the signs. Before a formal diagnosis is locked in, you have the vital observation phase. So, what exactly are you looking for when a patient walks through the door? Well, the visual and emotional clues can be incredibly striking. You might immediately notice their general appearance. Maybe they're wearing highly colorful or seductive clothing, or excessive makeup. They might appear hyperexcited or even threatening. But you've got to pay close attention to their affect. It's often described as labile and intense. What that means is their emotional expression shifts rapidly. They might be euphoric and expansive one minute, wildly irritable the next, and might even experience brief, sudden drops into depression right in front of you. This sheer unpredictability, that's your first major red flag.
As you interact with them, a whole cascade of cognitive symptoms is going to reveal itself. Their thought content is often dominated by highly elevated self-esteem, grandiosity, and profound egocentricity. They may even hold grandiose delusions. And all of this is driven by an underlying flight of ideas and racing thoughts. Honestly, it's like their brain is a car with a stuck accelerator and absolutely no brakes. Those racing thoughts directly translate into loud, pressured, dramatic speech that can be exaggerated to the point of total incoherence. Consequently, their cognition takes a massive hit. They become highly distractible, and their insight and judgment become extremely impaired, leaving them entirely unable to make rational decisions.
Section 3. Diagnosing a manic episode.
We've spotted the signs, but general observation isn't enough to make a medical determination, right? We've got to move into the strict, rigid diagnostic criteria. The defining standard here is the core manic rule. To officially diagnose a manic episode, the patient must have an abnormally and persistently elevated, expansive, or irritable mood paired with abnormally increased activity or energy. But the ultimate metric? It's the clock. This state must last for a minimum of 7 consecutive days, present for most of the day, nearly every day. Why 7 days? Because it definitively separates a fleeting mood swing from a sustained pathological neurochemical event. Now, there is one exception. If the severity is so intense that they require immediate hospitalization on day 2 or 3 just to keep them safe, the clock doesn't matter anymore. The criteria is instantly met.
Alongside that rigid duration, you need to literally count the specific symptoms to build your clinical case. The patient must actively exhibit at least 3 core symptoms. If their baseline mood is only irritable rather than euphoric, the threshold actually goes up. You need to see 4 of these. You're checking for that inflated grandiosity, a sharply decreased need for sleep where they feel totally fully rested after just a few hours. Are they far more talkative than usual?
Are they experiencing that flight of racing thoughts, severe distractibility, a sudden, intense surge in goal-directed activity, or excessive involvement in highly risky activities? And we aren't just talking about being adventurous here. We are talking about actions that could lead to painful, disastrous consequences. Think sudden, massive spending sprees or entirely reckless business investments. This breakdown brilliantly illustrates the crucial dividing line between hypomania and full mania. Hypomania only requires a 4-day minimum duration. While the energy is clearly up and noticeable to everyone around them, there are far less apparent cognitive deficits and much less functional impairment. Crucially, in hypomania, there are no psychotic symptoms and absolutely no need for hospitalization. Full mania, on the other hand, is a completely different beast. 7 days minimum, marked social or occupational impairment, possible psychotic features, and a frequent need for hospitalization to prevent the patient from harming themselves, either financially or physically.
Real quick, before we leave diagnosis, we need to acknowledge cyclothymia. Think of this as a chronic, lower-grade presentation. We are looking at numerous periods of hypomanic and depressive symptoms lasting for at least 2 years, but never quite meeting the full criteria for a major depressive, manic, or hypomanic episode. It typically onsets early, usually between ages 15 and 25. Interestingly, it often coexists with borderline personality disorder. And that makes our clinical detective work even more challenging, as we have to try to disentangle the overlapping mood shifts of two very distinct conditions.
Section 4. Ruling out alternatives.
Okay, we have our criteria, but our job as clinical detectives isn't quite done yet. We have 3 primary alternate suspects we must systematically rule out. First up, schizophrenia. How do we tell them apart? Well, in mania, the content of psychotic symptoms changes rapidly. The onset is fast, and there is a defining element of elation. But the golden differentiator here is interepisodic recovery. Bipolar patients typically experience full recovery between episodes, unlike schizophrenia. Next, we have organic disorders, especially in middle-aged or older patients. Here, you'll see disinhibition, sure, but without those underlying mood elements of mania. Finally, drug misuse. Obviously, you'd order a toxicology screen, but clinically, you'll note that drug-induced symptoms generally subside very quickly once the patient is in a controlled hospital environment.
Once we've ruled out those alternatives, it's really worth looking at why the patient actually has this disorder in the first place. 85%. That is the massive heritability rate of bipolar disorder. It operates through polygenic inheritance. That means it's not just one single bipolar gene, but a deeply complex web of genetic factors all working together. While major life events can definitely precipitate episodes, the underlying biological foundation is just staggering. MRI scans even reveal abnormal hyperintensities, essentially bright spots showing tissue changes in subcortical regions of the brain, tightly tied to excessive dopamine activity.
Understanding that root cause really helps us look forward to the prognosis. What actually predicts whether a patient is going to stabilize or struggle chronically? Well, a good prognosis is linked to having short durations of manic episodes, an advanced age of onset, few suicidal thoughts, good treatment compliance, and few coexisting medical problems. Conversely, a bad prognosis is statistically associated with male gender, poor premorbid occupational status, alcohol dependence, and the presence of psychotic or inter-episode depressive features.
Section 5. Step-by-step management.
We've got the diagnosis, we've definitively ruled out the alternatives, and we understand the prognosis. Now, we've got to slow the pace and look at the actual step-by-step management to achieve our ultimate goal, stabilizing the patient. Managing acute mania is a highly strict, staged process. Step 1 is almost always hospitalization. Because insight and judgment are so profoundly impaired, you simply cannot negotiate with acute mania. Securing the patient's physical safety is priority number 1. Step 2 involves deploying atypical antipsychotics. These can be used as monotherapy or as an adjunct to rapidly bring down the severe agitation and any psychotic features. Then, once that acute fire is put out, Step 3 is the introduction of mood stabilizers. This lays down the long-term chemical scaffolding needed to establish lasting balance.
Let's zero in on lithium for a second. It remains the absolute gold standard, the undeniable treatment of choice for the long-term maintenance of bipolar patients. However, it's essentially a highly sensitive instrument that requires constant calibration. It is definitely not a set-it-and-forget-it medication. Clinicians must rigorously watch for toxic buildup in the kidneys. It requires ongoing, vigilant clinical monitoring for renal and thyroid dysfunction, as well as tracking the development of fine tremors and managing significant weight gain, which, as you can imagine, can drastically affect a patient's willingness to actually keep taking it.
But what happens if lithium just isn't an option? You need an alternate toolkit, and you've got to carefully match the drug to the specific clinical presentation. Valproate and carbamazepine step up here. They are highly effective in acute mania, and they're the absolute go-to choices for rapid cyclers, patients having at least 4 episodes a year, or those in a mixed affective state, meaning they're experiencing manic and depressive symptoms simultaneously. They're also the primary backup if lithium is strictly contraindicated. On the other hand, if the patient is struggling primarily with the depressive pole, lamotrigine is specifically deployed to tackle bipolar depression.
And that brings us to a rather harsh statistical reality, and a final question for you to ponder. The data shows that less than 20% of bipolar patients achieve a period of 5 years of true clinical stability with good occupational performance. Nearly half are going to have multiple episodes, and 40% will develop a chronic disorder. So, as clinical detectives and healthcare advocates, with such a structured, detailed pathway available to us, how can we actually improve patient adherence to these rigorous step-by-step management plans? That is the real challenge ahead. Thanks for joining me on this explainer, and keep questioning the details.